we're tackling the deepest, most complex organ in the body, the central nervous system, specifically the high-yield facts of clinical neurology.
It's a massive undertaking. We're wrestling with syndromes that can, completely shatter a person's life. And the difficulty for anyone trying to learn or understand them is that they often present with identical initial symptoms.
Like a tremor or a shuffling gait, or just confusion.
Exactly. But they're rooted in wildly different cellular pathologies and demand completely distinct, sometimes even opposing treatment pathways.
Okay, let's unpack this. We've pulled together a huge amount of material. It covers everything from, subtle changes in how you walk to major, irreversible cognitive decline.
And we even have specialized disorders of the eyes and ears that link directly back to the CNS.
Right. Our source material is dense, almost like a detailed clinical review, and our mission today is to turn this intricate, interconnected web of symptoms, genetics, and pathology into clear, actionable knowledge for you.
We want to give you that mental checklist, the one that separates one devastating condition from another.
Absolutely. The goal here isn't just to memorize a list of facts.
No, it's about recognizing the critical diagnostic pivot points. Think about it. When you see a person with a shuffling gait, your diagnostic mind needs to rapidly pivot.
Is it a dopamine deficiency, like in Parkinson's?
Or is it a copper overload, something like Wilson disease?
Or could it be just too much fluid in the brain, like in normal pressure hydrocephalus?
Exactly. So we are breaking this down into 4 distinct memorable modules. We'll start with the dementias,
Then move through movement disorders.
then tackle systemic syndromes that bridge multiple organs, and finally wrap up with the sensory systems, ophthalmology, and otology.
Why should you care? Because recognizing the nuanced differences between, say, vascular dementia and Alzheimer's.
Or differentiating a benign essential tremor from a severe cerebellar intention tremor.
That is the high-value currency of clinical understanding. We're going to give you the distinguishing factors that stick with you long after this deep dive is over.
So let's start with the one that affects the most people globally: cognitive decline.
We really have to begin with Alzheimer's disease, or AD. It's the prototypical cognitive decline.
It is. When people think of memory loss, this is usually the disease they picture.
So what does that typical progression look like, starting with the earliest phase?
The hallmark of AD is that the decline is insidious. It's slow and it's subtle initially.
And memory loss isn't just generic, right? It starts with a very specific failure.
It does. It starts with declarative episodic memory impairment. This means trouble recalling new information and recent events. You remember your childhood perfectly, but you can't remember what you ate for breakfast this morning.
So it's not just forgetting where you put your keys. It's more like forgetting that keys are the mechanism used to start the car in the first place.
Precisely. And as the disease advances, the deterioration spreads beyond the hippocampus and those memory centers. We see a shift to executive dysfunction.
Okay, so that's things like impaired judgment, difficulty problem solving.
And a real inability to manage complex tasks, like balancing a checkbook or following a multi-step recipe. Cognitive flexibility just evaporates.
And as it moves into the intermediate stages, it so often affects behavior, which, that can be just heartbreaking for families.
That's right. Intermediate AD symptoms often involve significant behavioral and personality shifts. We see patients becoming profoundly apathetic, socially disengaged.
And sometimes irritable or even aggressive.
Yes. Then, late-stage AD involves aphasia, the loss of ability to use or understand language, and apraxia.
The inability to perform learned, purposeful movements, even though the motor function to do it is still technically intact.
Exactly. And this entire widespread degeneration is rooted in a fundamental cholinergic deficiency, a massive loss of acetylcholine-releasing neurons.
That brings us to the microscopic level, the pathological and genetic roots. Because this is where AD really differentiates itself completely.
Right. We have 2 key protein aggregates and a few key genes driving this whole process.
Let's start with the genetics. I've heard them called the 4 horsemen of AD risk.
That's a good way to think of it. 3 genes, APP, presenilin 1 and presenilin 2, are strongly linked to the aggressive, early onset, familial form of AD.
And APP, the amyloid precursor protein gene, is particularly relevant because of where it's located.
It's on chromosome 21.
And that links directly to Down syndrome.
Exactly. Because people with Down syndrome have 3 copies of chromosome 21, they have an extra dose of the APP gene.
Which is why they have a significantly increased risk of developing AD early in life, often in their 50s.
It is. Now, for the most common late-onset risk factor, the one most of the population has an allele for.
That would be ApoE, apolipoprotein E.
Right. The epsilon 4 allele is the major genetic risk factor for late-onset AD. It increases your odds and is considered pathologic.
But on the flip side, the epsilon 2 allele is thought to be somewhat protective.
It is, potentially by helping the brain clear that nasty amyloid precursor protein.
Okay, so let's go deep on those two defining pathological hallmarks you'd see on autopsy. How do we distinguish them spatially?
We have to be crystal clear on location here. The first hallmark are the extracellular neuritic plaques.
So these are forming outside the neuron.
Outside the neuron, in the space between cells, they're little protein clumps made of those amyloid beta or A beta trapping peptides. They essentially gum up the communication network outside the cells.
And then the second hallmark is what causes the structural breakdown within the cells themselves.
Those are the intracellular neurofibrillary tangles,
Yeah.
or NFTs. These are composed of hyperphosphorylated tau protein.
And tau is normally a structural protein, right? Part of the neuron skeleton.
It's part of the cytoskeleton, but when it gets hyperphosphorylated, it clumps up and destabilizes that internal structure. It essentially dissolves the neuron's ability to transport materials and maintain its shape, leading to cell death from the inside out.
So you have this attack from both outside and inside the neuron.
You do. We also sometimes spot something called Hirano-bodies, which are rod-shaped actin aggregates. But really, the plaques and tangles are the definitive duo.
When you have this massive microscopic degeneration, how does that translate into our current, symptomatic treatment strategies?
The treatment really aims to compensate for that known deficiency, the loss of acetylcholine.
So for mild to moderate AD, what's the first line?
First-line treatment is acetylcholinesterase inhibitors. These are drugs like Donepezil, galantamine, and rivastigmine.
And the mechanism is very direct.
Very. They just block the enzyme, acetylcholinesterase, that breaks down acetylcholine in the synaptic cleft.
So by inhibiting the breakdown, you're increasing the amount of available neurotransmitter.
You're compensating for those degenerating cholinergic neurons.
So we're not reversing the disease at all. We're just sort of turning up the volume on the remaining signals.
That's exactly right. And it's important to understand that it offers only modest, temporary improvement in cognitive and global function. Critically, it does not alter the underlying disease progression.
And the side effects.
Since they increase cholinergic activity everywhere, not just the brain, the most common side effects are GI-related. Things like nausea and diarrhea.
Okay, so once the disease progresses to moderate or severe AD, you shift strategies slightly and introduce a second class of drug.
Yes, at that point, we often add memantine. And this addresses a different pathological pathway entirely.
So memantine is an NMDA receptor antagonist. How does that help?
Well, it works by reducing something called glutamate excitotoxicity. Glutamate is the brain's main excitatory neurotransmitter, and when neurons are dying, they often release way too much of it.
Which then damages the surrounding healthy neurons, a toxic cascade.
The toxic cascade. Memantine blocks this.
So if the acetylcholinesterase inhibitors are kind of filling the deficiency bucket, memantine is trying to reduce the progressive damage caused by all that cellular stress.
That's a perfect way to put it. It helps improve the progressive symptomatic decline and can often mitigate the frequency of hallucinations, which become more common in the later stages.
What about adjunctive therapies like vitamin E?
The use of vitamin E is, well, it's a bit controversial. It's based on its antioxidant role, but frankly, the clinical trial evidence is weak. You see it prescribed often, though, mainly because it's very safe.
All right, let's shift gears to the second most common type of dementia, which is dementia with Lewy bodies, or DLB.
Right. And this disorder is so intertwined with Parkinson's disease because they share the same fundamental microscopic villain.
And that villain is alpha-synuclein.
Alpha-synuclein. DLB and Parkinson's disease dementia, or PDD, are grouped under the umbrella of alpha-synucleinopathies. And DLB is a major player, accounting for maybe 10 to 20% of all dementia cases.
And the distinction between DLB and PDD, it really just comes down to timing, but the pathology is identical.
It is. The accumulation of Lewy bodies, which are these round eosinophilic inclusions, primarily composed of that misfolded alpha-synuclein protein.
Okay, but where are these Lewy bodies accumulating in DLB patients? The location matters.
It matters a great deal. In DLB, they are found predominantly in the cerebral cortex.
Which explains why the cognitive symptoms are so prominent and appear so early.
Exactly. In contrast, in classical Parkinson's disease, they accumulate first in the substantia nigra pars compacta, that deep brain structure responsible for movement control.
Okay, let's focus on the DLB presentation. It's defined by a classic clinical triad that really makes the diagnosis click, plus the motor component.
Right. It's a very, very specific presentation. Number one is dementia.
But with a specific flavor, right?
Yes. Often starting with prominent executive and visuospatial deficits, so they struggle with navigation, complex planning, that sort of thing.
And number two is the fluctuations.
Dramatic, prominent fluctuations in cognition and attention. I mean, you can see a patient shift rapidly from being completely lucid and coherent to drowsy, confused, and unresponsive almost minute to minute. It's quite startling.
And the third part of the triad.
Visual hallucinations. These are frequent, they're well-formed, and often very detailed. The patient might describe seeing children or animals or complex patterns that just aren't there.
And then the fourth critical component is the motor symptoms, the Parkinsonism, and also the sleep issues.
Exactly. They often develop Parkinsonism, meaning those extrapyramidal motor symptoms.
The tremor, rigidity, slow movement.
All of it. The tremor, rigidity, bradykinesia,
Ugh.
and postural instability. And DLB is very strongly associated with REM sleep behavior disorder.
And that's where the normal paralysis during REM sleep fails and the person physically acts out their dreams, sometimes violently.
It can be. Now, for the central diagnostic challenge, distinguishing DLB from PDD. It's all about the temporal relationship between the movement symptoms and the cognitive symptoms.
This is the high-yield distinction you need to know.
This is it. We call it the one-year temporal rule.
Okay, so break that down for us.
Parkinson's disease dementia, or PDD, is diagnosed if the dementia occurs more than 1 year after the onset of the characteristic Parkinsonism motor symptoms.
So motor symptoms first, for at least a year, then the dementia.
Right. But dementia with Lewy bodies, DLB, is diagnosed if the cognitive impairment occurs within 1 year of the Parkinsonism symptoms, or if it actually precedes the motor symptoms altogether.
So the timestamp dictates the diagnosis and helps predict the overall clinical course.
It does. And that leads to a really complicated treatment nuance, because what helps the movement often hurts the mind.
You've hit on the critical point there.
For the cognitive symptoms in both DLB and PDD, we use cholinesterase inhibitors, just like in AD. But treating the motor symptoms, the Parkinsonism, is a tightrope walk.
Because you need dopamine replacement, like levodopa or dopamine agonists.
Right, but increasing dopamine activity too much can severely exacerbate the already common visual hallucinations and psychotic symptoms that are so prevalent in DLB.
So the clinical decision becomes balancing the patient's mobility against the risk of inducing a severe psychosis.
Precisely. We often have to use lower doses of the dopamine agents. And if antipsychotics are absolutely necessary to control severe hallucinations or psychosis, we have to choose very carefully.
Atypical agents, right?
Yes. Something like low-dose quetiapine or pimavanserin, because the standard typical antipsychotics can severely worsen the motor symptoms and rigidity of Parkinsonism. It's a very delicate balance.
Let's shift our focus completely now from protein misfolding to problems of, well, plumbing, vascular dementia.
A very different mechanism. VADD is fundamentally a consequence of cumulative damage from stroke or cerebrovascular disease. The core difference is the pattern of decline.
Walk us through that pattern. It's not the smooth, insidious slide we see in Alzheimer's.
No, the key characteristic is an abrupt, stepwise decline.
A stepwise decline. What does that look like in practice?
A patient will be cognitively stable, then they suffer a vascular event, a stroke.
And that's the step down.
That's the step down. They stabilize at a new, lower level of function for a time, and then they might suffer another stroke, and there's another step down. This contrasts so sharply with the steady, gradual decline of AD.
And cognitively, what are the first domains to fail in VAD? Is it memory, like in Alzheimer's?
It's often the frontal lobe functions that fail first. Impaired executive function, so organization, planning, processing speed, that frequently presents before you see significant memory deficits.
And I imagine they also have other neurological signs.
Often, yes. Patients frequently have focal neurological deficits, specific motor, sensory, or visual symptoms that reflect the areas of the brain where the previous strokes occurred.
It makes sense then that the risk factors are identical to those for heart disease and stroke.
They're completely overlapping. Advanced age, uncontrolled hypertension, diabetes, hyperlipidemia, existing coronary artery disease, and any source of embolism, like atrial fibrillation.
So since the pathology is damaged tissue from poor blood flow, the treatment has to focus entirely on prevention, not on neurochemical manipulation like in AD.
That is the crucial clinical takeaway. Diagnosis is based on the history, physical exam, and neuroimaging that shows evidence of cerebrovascular disease like multiple infarcts or widespread white matter lesions.
And the treatment?
It is entirely centered on aggressive, targeted management of those stroke risk factors. Antiplatelets, statins, blood pressure control, diabetes management, all to prevent the next step of decline.
Okay, on to frontotemporal dementia, or FTD, sometimes called PIC disease. This one often hits younger people, typically in their 50s and 60s.
It does, and the behavioral changes are often the most devastating symptom for the family because the person they know just seems to vanish.
So what's happening in the brain?
FTD involves selective atrophy of the frontal and/or temporal lobes. And since the frontal lobe controls our social filter and executive function, its degeneration leads to some highly distinct clinical subtypes.
Let's detail the behavioral variant, BVFTD, which is the most common and I think the most dramatic presentation.
BVFTD is a complete loss of the social self. You see profound disinhibition leading to socially inappropriate behavior,
A total loss of their filter.
a total loss. There's a startling loss of empathy and emotional coldness coupled with apathy. They might exhibit hyperorality, binge eating, or compulsively putting objects in their mouth, and highly ritualized compulsive or repetitive behaviors.
It must feel like an entirely different person has taken over.
It does. The other main subtype is primary progressive aphasia, or PPA. And this is fascinating because the initial symptom is impairment of speech and language aphasia, while memory and other cognitive functions remain relatively intact early on.
Microscopically, what defines FTD?
The classic finding is the presence of PIC bodies. These are spherical or round intracellular aggregates of hyperphosphorylated tau proteins.
So similar to the tangles in Alzheimer's, but different.
Similar protein, tau, but morphologically distinct and concentrated in these specific brain regions.
And what does imaging tell us? Must be pretty stark.
It is. An MRI will reveal striking atrophy that's really concentrated in the frontal and/or temporal lobes. And if you look at metabolic activity using an FDG PT scan, you'll see corresponding areas of hyperperfusion and hypometabolism specifically in those regions. The brain tissue is just starving and shrinking.
Given those very specific protein aggregates, are we able to slow this disease down at all?
Unfortunately, no. FTD currently has no disease-modifying therapies. Treatment is purely supportive, focusing heavily on managing the challenging behavioral symptoms, agitation, depression, aggression, often using symptomatic medications, but without addressing the underlying neuronal death.
Okay, let's move to normal pressure hydrocephalus, or NPH. This is one of the most exciting diagnoses in neurology because it is one of the few potentially reversible causes of dementia in older adults.
Absolutely. And we rely on that classic triad to recognize it.
The wobbly, wet, and wacky triad.
Every learner must know this triad and know it well, because missing NPH means missing a chance for significant recovery.
So wobbly is gait ataxia, wet is urinary incontinence.
And wacky is dementia, specifically focusing on psychomotor slowing, concentration, and attention deficits.
Let's delve into the wobbly part. What makes the gait in NPH so distinct, especially when you compare it to the shuffling gait of Parkinson's?
The NPH gait is often described as magnetic. The feet barely lift off the floor as if they're stuck to a magnet.
Right, and while it can resemble Parkinson's disease,
It's different. NPH patients typically have a wider base, they lack the characteristic resting tremor, and they don't have the cogwheel rigidity you see in PD.
so what is happening inside the brain to cause this magnetic sticking and the rest of the triad?
NPH is caused by impaired cerebrospinal fluid, or CSF, absorption. The fluid isn't draining correctly.
So it backs up.
It backs up, leading to the stretching of the brain's ventricles, which we call ventriculomegaly. This stretching then pulls on the surrounding white matter tracts, specifically the corona radiata.
Those are the nerve fibers that descend from the motor cortex to control the legs and bladder.
Precisely. That mechanical stretching is what causes the gait and urinary issues.
How do we confirm an NPH diagnosis and, importantly, distinguish it from other types of brain shrinkage, like in Alzheimer's?
The best initial test is a non-contrast CT or MRI. The definitive imaging finding is ventriculomegaly enlarged ventricles without significant sulcal enlargement.
That's the key distinction.
It is. In AD, the whole brain shrinks, so the spaces get larger, both the ventricles and the sulci, the grooves on the brain surface. In NPH, the ventricles enlarge because of pressure, but the outer surface of the brain isn't shrinking, so the sulci remain small.
And the treatment is so dramatic because of that potential for reversibility.
The treatment is a ventriculoperitoneal, or VP, shunt. It's a neurosurgical procedure that diverts the excess CSF, usually into the abdominal cavity, where it can be absorbed.
And you can test to see if it will work beforehand.
We can. We often use a diagnostic tool first, a high-volume lumbar puncture or a temporary lumbar drainage trial. We remove a large amount of CSF and see if the patient's symptoms improve. If they do, they're good candidates for a permanent shunt.
Which symptom usually gets better first after the shunting?
Gait improvement is often the most dramatic and quickest response. This is usually followed by moderate improvement in urinary and cognitive symptoms. It really is a satisfying diagnosis to make.
We transition now from the reversible to the rapidly, brutally fatal Creutzfeldt-Jakob disease. CJD is rare, but it's terrifying because of its speed.
CJD is the quintessential prion disease. It is a spongiform encephalopathy, meaning it causes the brain tissue to become riddled with holes like a sponge.
And it's caused by an abnormal protease-resistant prion protein.
Right. And the critical characteristic is speed. It causes a rapidly progressive dementia, usually leading to death within a year, sometimes within just a few weeks of symptom onset.
What defines the clinical course besides that hyperspeed decline?
Patients present with a subacute dementia, often combined with ataxia, so loss of coordination, and very characteristically, myoclonic jerks.
These are those sudden, lightning-quick, involuntary muscle twitches.
Yes, and they're often dramatically induced by startle. A loud noise or a bright light can trigger them.
I seem to recall hearing about specific variants, like the one linked to contaminated food.
Yes, the classic CJD is spontaneous, but we also recognize new variant CJD, which was famously linked to consuming contaminated beef, so bovine spongiform encephalopathy, or mad cow disease.
And there's also an iatrogenic form.
There is. Iatrogenic CJD has historically been transferred through contaminated medical materials, like corneal transplants or improperly sterilized neurosurgical tools. Thankfully, strict sterilization protocols have largely mitigated this risk.
Given the speed and severity, how do we confirm this diagnosis? It sounds difficult.
A definitive diagnosis is postmortem, via brain biopsy or autopsy. However, we have highly suggestive tests that allow for a probable clinical diagnosis.
Like what?
These include detecting a protein called 1433 in the CSF, seeing periodic sharp wave complexes on an EEG, and using the highly sensitive real-time quaking-induced conversion, or RTQIC, assay.
And that actually detects the abnormal prion protein itself.
It does in the CSF.
And I seem to recall something about a specific imaging finding, a visual marker of that rapid neuronal destruction.
You're thinking of the MRI findings. A brain MRI will often show hyperintensity in the caudate and putamen deep brain structures, which, when viewed together, can resemble a hockey stick sign.
You might also see cortical ribboning.
Right, a linear hyperintensity along the cortex, reflecting that rapid and widespread neuronal damage. Since it's a prion disease, the progression can't be halted. Treatment is purely supportive.
We just left the slow, terrifying decline of the dementias and the hyperspeed destruction of CJD. Now let's shift our focus entirely to how the brain fails when trying to execute commands.
Moving from cognitive failure to the failure of motion control.
Starting with the hyperkinetic conditions where there is simply too much motion, and that means we have to start with Huntington disease.
Huntington's is the poster child for hyperkinetic disorders. It is a devastating autosomal dominant neurodegenerative disease. If you inherit the gene, you will develop the disease.
And the genetics are defined by those infamous trinucleotide repeats, specifically CAG.
That's right. It's caused by excessive CAG cytosine adenine guanine repeats on chromosome 4. Once you cross the critical threshold, which is usually more than 36 repeats, the Huntington protein that's produced becomes unstable and toxic.
How does that single genetic error translate into the excessive, uncontrolled movement we see?
Well, the abnormally long Huntington protein triggers something called glutamate excitotoxicity, which causes selective neuronal death.
But it's very specific about which neurons it kills first.
Very specific. The cells that die first are the GABA and acetylcholine-releasing neurons in the striatum, that's the caudate, and the putamen.
And these neurons act as the brain's inhibitory brake on movement.
Precisely. So when that brake is removed, the dopamine circuitry is thrown out of balance, resulting in unbalanced excessive dopamine activity. And that is the driver of the chorea, those rapid, writhing, dance-like movements.
The clinical presentation is defined by a triad of symptoms, often leading to a diagnosis between 30 and 50 years old.
Yes, the HD triad. First is motor.
Which starts out as hyperkinetic.
Right. Early signs are chorea, sutics, and hyperreflexia. This progresses to severe writhing movements, dystonia, and then eventually in the late stages, patients can become rigid and bradykinetic.
Second is cognitive.
A subcortical type of dementia affecting memory retrieval and executive function.
And third is mood and psychiatric symptoms.
A very high incidence of depression, anxiety, aggression, paranoia, and psychosis. It is absolutely essential to screen for psychiatric history and, unfortunately, suicide risk, as this often runs deep in affected families.
The imaging must reflect that profound loss of the inhibitory cells in the striatum.
It does. I mean, genetic testing is what confirms the diagnosis, but imaging, specifically a CT or MRI, shows a very distinctive pattern,
Yeah.
marked atrophy of the caudate and putamen.
And that loss of tissue caused a compensatory enlargement of the lateral ventricles in that region.
Leading to a visual effect known as boxcarring of the lateral ventricles.
And since we can't replace those dead neurons, treatment is purely symptomatic, just trying to calm down that excessive dopamine activity.
Correct. The chorea is primarily managed by reducing dopamine activity. We use VMAT2 inhibitors, dopamine-depleting agents like tetrabenazine or deuterbenzine, or sometimes atypical antipsychotics. Mood symptoms are treated separately with SSRIs.
Okay, so moving from too much movement, hyperkinetic, to too little hypokinetic, we come to Parkinson's disease. This is the opposite side of that basal ganglia dysfunction coin.
It is. PD is a slowly progressive neurodegenerative disorder defined by the loss of neuromelanin-containing dopaminergic neurons in the substantia nigra pars compacta, or SNPC.
It's the engine of the basal ganglia movement circuit that's failing.
That's right. And the pathological hallmark is the presence of those alpha-synuclein-containing Lewy bodies, initially found right there in the SNPC.
Before the major motor symptoms hit, what are some of the common early warning signs that patients or their family members might notice?
Well, PD typically presents after age 50, and increasing age is the primary risk factor. But years before the motor signs, patients often report things like constipation, anosmia, which is loss of smell, generalized fatigue, and similar DLB, REM sleep behavior disorder.
And there's that odd protective factor.
Yes. Nicotine exposure from smoking has been consistently shown to be oddly protective. Of course, we don't encourage smoking as a protective strategy.
Of course not. Clinically, we summarize the motor features with the TRA-PSS mnemonic. Let's make sure we clearly define each component of that.
TRA-PSS is your checklist. T stands for tremor.
A very specific kind of tremor.
A classic unilateral resting tremor, 4-6 hertz, often called pill rolling. And the critical distinction is that it improves with voluntary movement.
Okay, R is for rigidity.
Resistance to passive movement. This can be constant resistance, which we call lead pipe, or a jerky resistance, which is cogwheel.
Next is A for akinesia or bradykinesia.
Slowness of movement. This manifests as reduced arm swing when walking, small shuffling steps, a fascinating gait, and small cramped handwriting, which we call micrographia.
P is for postural instability.
Right. Impaired balance, leading to a tendency to fall, which is often worsened by turning.
And the final two S's cover the non-motor symptoms.
Yes. S for sympathetic or autonomic dysfunction, so orthostatic hypotension, sweating, urinary urgency. And the final S for sleep issues, like that REM sleep behavior disorder.
Since the problem is a lack of dopamine, the treatment strategy has to focus on replacement, conservation, or direct agonism.
The general goal is to restore that delicate basal ganglia balance, increasing dopaminergic activity and, at the same time, decreasing the relative strength of the cholinergic activity.
Let's segment the treatment based on age and symptom severity, starting with younger patients or those with milder symptoms.
For patients under 65 or those with very mild symptoms, we often try to delay the use of levodopa
Why is that?
because of its association with motor complications later on. So we might start with non-ergot dopamine agonists like pramipexole or ropinirole, which mimic dopamine and stimulate the receptors directly.
Or another option.
Alternatively, we use MAOB inhibitors like selegiline or risagiline. These centrally prevent the breakdown of dopamine so they can serve what little the patient is still producing.
But when symptoms become moderate or severe or the patient is older, we have to bring in the big gun, levodopa. Why do we always pair it with carbidopa?
This is a crucial pharmacological concept. Levodopa is the key that unlocks the treatment, but it's a fragile key.
What do you mean by that?
If we give levodopa alone, it's rapidly broken down by an enzyme called dopa decarboxylase peripherally in the bloodstream before it can even cross the blood-brain barrier. So very little reaches the brain, and you get severe systemic side effects like nausea.
So carbidopa acts like a shield or a bodyguard.
Exactly. Carbidopa is a peripheral dopa-dopa decarboxylase inhibitor. It acts as a shield, blocking that enzyme in the bloodstream. By doing so, much more of the levodopa reaches the brain, crosses the blood-brain barrier, and is then converted to dopamine where it's needed.
Which dramatically increases its effectiveness and reduces those peripheral side effects.
That's why we always use the combination.
Okay, if a patient is doing well on levodopa but starts experiencing the wearing off phenomenon between doses, how do we adjust that?
That indicates the drug just isn't lasting long enough, so we can introduce COMT inhibitors like anticapone.
And COMT is another enzyme that breaks down levodopa.
Right. By inhibiting COMT, we extend the half-life of levodopa, which maintains steady plasma levels and smooths out those wearing-off fluctuations.
A final quick note on treating the tremor specifically. Anticholinergics are used, but we have to be incredibly careful, especially with older patients.
Yes, anticholinergics, like trihexyphenidyl, are highly effective for the tremor component, especially in younger patients. But you have to remember the side effect profile, which is summarized by that rhyme.
Blind as a bat, dry as a bone, mad as a hatter.
Exactly. Blind as a bat for mydriasis or impaired vision, dry as a bone for dry mouth and constipation, and mad as a hatter for confusion and psychosis. Those side effects, particularly the confusion, make them very risky for the elderly.
Since tremor is such a common symptom in neurology, let's take a moment to classify the three major types by their timing and appearance, because that classification really dictates the treatment.
Right. We use timing.
Hmm.
Does it occur at rest or during action?
So, resting tremor.
A resting tremor occurs when the body is completely relaxed, and it improves dramatically with voluntary action. The classic example is, of course, the Parkinsonian tremor.
That 4-6 hertz pill rolling motion.
Yes. And the treatment is dopaminergic agents.
Then we have action tremors, which occur when the person is doing something or holding a posture against gravity.
And we divide action tremors into two main categories. First is essential tremor, or ET.
This is the most common movement disorder, right?
It is. It's a bilateral fine tremor, about 612 hertz, that occurs when maintaining a posture, like holding a glass or performing a kinetic task. It often has an autosomal dominant familial inheritance pattern.
Is there one characteristic observation that immediately helps distinguish essential tremor from other action tremors?
Yes. The classic test, or observation, is its transient improvement with a small amount of alcohol intake. That's a key diagnostic feature.
And the treatment?
First-line treatment for essential tremor is propranolol, a beta blocker, or primidone, which is an anticonvulsant.
And the most severe, often asymmetrical action tremor is the intention tremor.
This is a coarse, low-frequency tremor, maybe 2 to 4 hertz, that gets dramatically worse as the hand gets closer to its target.
This is called target dysmetria.
Right. If you ask a patient to touch your finger, they will shake more violently the closer they get. This is the hallmark of cerebellar outflow disease. Unfortunately, we have no specific drug treatment for this tremor. Treatment has to focus on addressing the underlying cerebellar cause, like a stroke or a tumor.
Let's move to amyotrophic lateral sclerosis, or ALS Lou Gehrig's disease. This is so devastating because it is purely a disease of the motor system.
It is. It preserves cognitive function and consciousness while systematically dismantling the body's ability to move. It's defined by the convergence of upper and lower motor neuron signs.
So ALS is a progressive, relentlessly fatal motor neuron disease.
With a median survival of only 3 to 5 years. It's a selective killer, targeting the motor neurons in the cortex, the UMNs, and in the spinal cord and brainstem, the LMNs.
What are the specific signs that differentiate upper motor neuron damage from lower motor neuron damage? Let's clarify that.
Okay. Lower motor neuron signs result from damage to the final common pathway, the peripheral nerves, and the spinal cord motor neurons. These include weakness, muscle atrophy or wasting, flaccid or hypotonic limbs, and those visible, localized muscle twitches we call fasciculations.
And upper motor neuron signs?
Upper motor neuron signs result from damage to the motor cortex and the corticospinal tracts. These include spasticity or stiffness, hyperreflexia, exaggerated reflexes, and the classic Babinski sign, the extensor plantar response.
It's just devastating to think about that specific neurological isolation. The motor function fails while the mind remains completely sharp.
That isolation is a core tragedy. About 20% of patients present with what we call bulbar onset.
Meaning the initial weakness affects the muscles controlled by the brainstem cranial nerves?
Right, leading to severe difficulty speaking, which is dysarthria, and swallowing, dysphagia. These patients also frequently experience pseudobulbar effect.
Uncontrollable, context-inappropriate bouts of laughing or crying.
Yes, which is a sign of UMN damage to the pathways that control emotional expression.
What parts of the nervous system are conspicuously spared? This is crucial for diagnosis.
The areas that are typically spared are the sensory system, so patients maintain sensation, cognitive and memory function, and sphincter control, so bowel and bladder function. If you see significant sensory loss or severe early dementia, it really suggests a diagnosis other than ALS.
Given its progressive nature, treatment options are limited, but they are important for quality of life and survival time.
Treatment is primarily supportive, managing symptoms like spasticity and especially respiratory failure, which is the ultimate cause of death. But we do have two specific disease-modifying agents that offer modest benefit.
The first is riluzole.
Riluzole. This works by inhibiting glutamate-induced excitotoxicity and has been shown to modestly prolong life by maybe 2 to 3 months.
And the second is edaravone.
Edaravone. This is an intravenous antioxidant that helps slow the rate of functional decline.
We've established that neurological conditions can be the end result of larger systemic issues. So let's connect the brain to other body systems, starting with metabolic diseases.
And we have to start with Wilson disease, or hepatolenticular degeneration.
Wilson disease is a classic metabolic trap.
It is. It's an autosomal recessive disorder caused by a mutation in the ATP7B gene, which is critical for copper transport.
So this defect prevents copper from being properly excreted into bile or integrated into its carrier protein, ceruloplasmin.
Right. And the result is a toxic accumulation of copper throughout the body.
Where does this copper accumulate and cause the most damage?
The primary targets are the liver, the brain, specifically the basal ganglia and lenticular nuclei, hence the name hepatolenticular degeneration.
As well as the kidneys and the cornea.
Yes, it can cause renal tubular dysfunction like Fanconi syndrome, and then the classic corneal findings.
What should immediately trigger the thought of Wilson disease in a clinical setting?
You should think of Wilson disease if you see a combination of liver disease, jaundice, hepatitis, or cirrhosis, and new-onset neurological symptoms.
Things like dystonia, dysarthria, or Parkinsonism.
Especially in a person younger than 40. That combination must prompt the diagnostic workup.
And the characteristic ocular sign that really confirms the diagnosis.
Kaiser-Fleischer rings. These are copper deposits in Descemet's membrane in the cornea. They look like a yellow-brownish ring visible around the iris.
You sometimes need a slit lamp exam to see them clearly.
Often you do. Diagnosis then relies on a combination of laboratory findings.
You'll screen with liver function tests, but the key diagnostic findings are
A low ceruloplasmin level, usually under 20, because the copper isn't being incorporated properly, and then high urinary copper levels over 100, reflecting the body trying to dump the excess copper.
Since copper is the culprit, the treatment is all about getting it out.
Absolutely. Treatment focuses on chelation and binding. We use chelating agents like penicillamine and trientine to remove the excess copper from tissues, and we also use oral zinc.
And that blocks copper absorption in the gut.
Right, making it a great maintenance therapy.
This next group of syndromes provides vivid examples of genetic errors that link neurological pathology to visible skin manifestations. Neurofibromatosis type 1, or NF1, is the most common.
NF1 is an autosomal dominant disorder that stems from a mutation in a tumor suppressor gene. The diagnosis requires meeting 2 or more very specific criteria.
You're looking for things like 6 or more café au lait spots.
Right, those large, flat, pigmented macules. Or 2 or more neurofibromas, which are benign peripheral nerve sheath tumors.
You also see freckling in the axilla or groin or an optic glioma.
And another classic finding is 2 or more Lisch nodules, which are pigmented iris hamartomas.
What about NF2? It's characterized by a very specific location for tumor growth.
NF2 is also autosomal dominant, and the hallmark is the presence of bilateral vestibular schwannomas.
Also known as acoustic neuromas.
Right. Alternatively, a diagnosis can be made if a first-degree relative has NF2 and the patient has a unilateral schwannoma or any 2 other related tumor types like meningiomas or gliomas.
And these vestibular schwannomas classically compress cranial nerves the 7th and 8th,
causing the clinical symptoms of hearing loss, tinnitus, and vertigo.
Let's briefly mention tuberous sclerosis, or TS, and its connection to the mTOR pathway.
Tuberous sclerosis is characterized by facial angiofibromas, specific hypopigmented skin patches like Ashley spots and Shireen patches, and often severe seizure disorders.
And the underlying molecular mechanism is linked to that mTOR pathway,
which is a major cell growth regulator. Because of this, treatment often involves using mTOR inhibitors to manage symptoms and reduce tumor growth.
Okay, moving to the vascular category, Sturge-Weber syndrome.
This is a fascinating condition because it's caused by a somatic mosaic mutation in the GNAQ gene.
Meaning it occurs after conception and is not inherited.
Right. Its defining feature is a facial capillary malformation. commonly known as a port wine stain, typically distributed along the V1 division of the trigeminal nerve.
And the internal consequences are what drive the severe neurological symptoms.
That's right. Internally, patients have a leptomeningeal angioma, a vascular malformation covering the brain surface. This often leads to focal seizures, intellectual disability, and glaucoma.
And on imaging, you look for those characteristic intracranial calcifications.
Often described as having a tramline or railroad track appearance.
Finally, von Hippel-Lindau or VHL syndrome, another multisystem tumor suppressor mutation.
VHL is autosomal dominant. It's associated with a range of tumors, the most prominent being hemangioblastomas.
These are vascular tumors most commonly found in the CNS.
Specifically, the cerebellum and spinal cord, presenting with headache, ataxia, or vision loss. VHL patients are also at high risk for retinal hemangioblastomas, clear cell renal cell carcinoma, which is a major threat, and pheochromocytomas.
Given that it is a tumor suppressor gene pathway that is disrupted, how do the modern treatments leverage that knowledge?
Treatment is surgical for symptomatic masses, but we've made strides in molecular therapy. The VHL gene regulates the HIF-1 alpha and HIF-2 alpha transcription factors.
Which are key in promoting a tumor's blood supply.
Exactly. So treatment protocols now include HIF transcription factor inhibitors to target and disrupt this pathway, offering hope beyond just surgical management.
Let's discuss idiopathic intracranial hypertension, or IIH, sometimes called pseudotumor cerebri, where the pressure in the head is high, but there's no mass or obvious cause.
IIH is defined by an elevated intracranial pressure, or ICP, measured as over 25 centimeters of water during a lumbar puncture, but without any space-occupying lesion.
And the classic demographic is obese young women.
It is, suggesting a strong hormonal or metabolic component, though the exact cause remains idiopathic.
What are the primary symptoms of this chronic high pressure?
Patients typically complain of a chronic, often pulsatile headache, which is worsened by bending over. The critical physical finding is papilledema.
Swelling of the optic disc.
Yes, which can cause transient vision loss and, if it becomes chronic, irreversible blindness. They may also report pulsatile tinnitus, hearing their own heartbeat in their ears.
Since vision loss is the major long-term threat, how do we treat it?
Treatment starts with addressing the main risk factor, weight loss, which can be highly effective. Pharmacologically, the first-line treatment is acetazolamide.
A carbonic anhydrase inhibitor that directly decreases CSF production.
Right, thereby lowering the pressure. If vision is severely threatened, surgical interventions like optic nerve sheath fenestration or CSF shunting are necessary to decompress the optic nerve.
Now, let's transition to the neurological syndromes caused by simple vitamin deficiencies. Starting with thiamine, vitamin B1.
Thiamine deficiency, most commonly seen in chronic alcoholism or malnutrition, is responsible for Wernicke encephalopathy. This has a classic triad.
Acute confusion, ataxia, and ophthalmoplegia.
Exactly. Confusion, difficulty walking, and gaze palsies, specifically nystagmus or weakness in eye movement.
And if Wernicke's isn't treated early, it leads to an irreversible form of dementia.
Correct. It progresses to Korsakoff dementia. This is characterized by severe anterograde amnesia, inability to form new memories, and retrograde amnesia, so loss of old memories. Uniquely, they also develop confabulations.
The spontaneous creation of false memories to fill in the gaps.
Right. And there is a critical life-saving rule regarding treatment.
This is non-negotiable in the clinical setting.
Always give thiamine before giving glucose.
Why is that so important?
Because glucose metabolism requires thiamine as a cofactor. If the patient is already severely thiamine deficient, flooding their system with glucose rapidly depletes the remaining reserves, which can precipitate or severely worsen the Wernicke-Korsakoff syndrome.
Okay, finally, cobalamin, or vitamin B12 deficiency.
B12 deficiency leads to a condition called subacute combined degeneration, or SCD. This involves the demyelination, the loss of the protective sheath of specific white matter tracts in the spinal cord.
The dorsal columns and the corticospinal tract.
Yes, and the clinical consequences of that specific demyelination.
Well, dorsal column damage causes loss of proprioception, your sense of position, and vibration sense,
leading to sensory peripheral neuropathy and gait ataxia. And the corticospinal tract damage can lead to weakness and some UMN signs. Treatment is simple and effective. Intramuscular B12 injections.
We've spent a lot of time on the central nervous system, but now we shift to the peripheral sensory systems, the eyes and ears, which are, of course, highly integrated with the CNS.
Starting with common infections of the eye.
Let's distinguish between the two most common external lid lesions. A hordeolum, or stye,
is an acute, painful, localized infection, usually staph, of the oil glands. It's an acute abscess.
In contrast, a chalazion.
Is a chronic, non-tender, firm nodule. It's a sterile granulomatous inflammation, often resulting after ordeolum resolves. Both are usually managed initially with warm compresses.
Okay, moving inward. If the cornea is scratched, the main threat is infection, especially if the person wears contact lenses.
Corneal abrasions cause severe pain, a foreign body sensation, and photophobia. We confirm the diagnosis with fluorescein dye, which pools over the defect.
And the immediate treatment goal is preventing infection.
Particularly from Pseudomonas and contact lens users, which can rapidly cause corneal ulceration and blindness. Topical broad-spectrum antibiotics, like a fluoroquinolone, are standard.
And the distinction between bacterial and viral conjunctivitis is a foundational clinical concept.
Bacterial conjunctivitis presents with that thick, purulent discharge, a goopy eye, and eyelid matting, often caused by common bugs like Staphylococcus or H. flu.
Whereas viral conjunctivitis,
Most commonly, adenovirus presents with copious watery discharge, severe irritation, and a classic finding: preauricular lymphadenopathy, so swollen lymph nodes in front of the ear.
we also need to highlight the specific severe bacterial causes that mandate specific treatment.
Neisseria gonorrhea is a true emergency. It causes a hyperacute purulent discharge and can rapidly perforate the cornea, necessitating prompt admission and high-dose 5E ceftriaxone.
And the other big one is chlamydia.
Separately, chlamydia trachomatis causing trachoma is crucial because it remains the leading infectious cause of preventable blindness globally.
When does an infection cross from being a local eye problem to a life-threatening neurological emergency?
That happens with orbital cellulitis, the postseptal infection. This means the infection has spread deep behind the orbital septum into the fat and ocular muscles.
Often originating from adjacent sinus infections.
Yes. And because the deep orbital vessels connect directly to the cavernous sinus in the brain, it carries a high risk of spreading to the CNS. It requires immediate admission and aggressive IV broad-spectrum antibiotics.
Usually vancomycin plus a third-generation cephalosporin or metronidazole.
That's right. And what about uveitis?
Uveitis is inflammation of the uvea, the iris, ciliary body, and choroid. Symptoms are eye pain, redness, photophobia, and visual changes.
Crucially, it is often non-infectious and linked to underlying systemic inflammatory disorders like ankylosing spondylitis or inflammatory bowel disease.
So treatment is targeted at the specific etiology, often involving topical or oral steroids.
Moving on to glaucoma. It's often called the silent thief of sight, caused by increased intraocular pressure, or IOP, that damages the optic nerve head.
Causing progressive, often peripheral vision loss first.
We have to distinguish the two main types. Open-angle glaucoma, or OAG, is the most common form, gradual and painless.
And it happens because the trabecular meshwork, the drainage filter, offers too much resistance to the aqueous humor outflow over time.
Exactly. Key risk factors include age over 40, a strong family history, Black ethnicity, and diabetes.
And the key diagnostic finding is the characteristic cupping of the optic nerve head on a fundoscopic exam,
where the cup, the center depression, is enlarged relative to the optic disc. Treatment for OAG focuses on increasing outflow or decreasing aqueous production.
First-line medical therapy uses topical medications like prostaglandin analogs to increase outflow or beta blockers and carbonic anhydrase inhibitors to decrease aqueous production.
And laser trabeculoplasty is used if drugs fail.
Now contrast that with closed-angle glaucoma, or CAG, which is a mechanical acute emergency.
CAG is a sudden, painful event where the iris physically bunches up and obstructs the drainage angle, causing a rapid spike in IOP.
The symptoms are explosive.
Sudden severe pain, blurry vision, a fixed and mid-dilated pupil, and often nausea and vomiting due to the extreme pressure.
What is the most crucial clinical warning about managing a CAG patient?
You must avoid drugs that cause mydriasis pupillary dilation like anticholinergics.
Because dilation will physically cram the iris even further into the drainage angle, worsening the occlusion.
Exactly. Treatment involves a rapid sequence of topical and systemic medications to lower IOP immediately, followed by a surgical peripheral iridotomy.
And finally, a quick word on cataracts.
Cataracts are simply the opacification or clouding of the lens. Risk factors include advanced age, diabetes, hypertension, and chronic steroid use.
The patient reports a gradual, painless blurring of vision.
And the treatment is surgical. Removal of the opaque lens and replacement with an artificial intraocular lens.
Age-related macular degeneration, or AMD, is the leading cause of irreversible vision loss in older adults, and it specifically attacks central vision.
AMD targets the macula, which is the small central part of the retina responsible for detailed vision. Patients complain of metamorphopsia,
where straight lines appear wavy or distorted.
which is a key symptom of macular damage.
What are the differences between the dry and wet types?
Dry or atrophic AMD is the most common, about 80% of cases. It's gradual, characterized by the accumulation of drusen extracellular yellow deposits.
And there's no cure for that.
No, but high doses of specific antioxidants like vitamin C, E, zinc, and beta-carotene may slow its progression.
And then there's wet AMD.
Wet or exudative AMD is severe and rapid. It involves the growth of abnormal leaky new blood vessels beneath the retina, causing hemorrhage and severe vision loss.
And the treatment for wet AMD is aggressive and targeted.
The breakthrough treatment is anti-VEGF inhibitors, like bevacizumab. These are injected directly into the eye intravitreally to inhibit the growth of those abnormal new blood vessels and reduce the leakage and hemorrhage that cause the rapid loss of vision.
Let's discuss retinal vascular occlusions. These are the equivalent of strokes or heart attacks in the eye, starting with central retinal artery occlusion, or CRAO.
CRAO is a genuine ocular stroke. It presents with sudden, painless, complete unilateral vision loss. The classic finding on fundoscopic exam is the cherry red spot on the fovea,
contrasting sharply with the pale, ischemic surrounding retina.
Right. The cause is usually an embolus from carotid atherosclerosis or atrial fibrillation.
Now, if the patient is over 50, a critical differential must be ruled out immediately because it requires a completely different treatment.
Absolutely. If the patient is over 50, you must immediately investigate for giant cell arteritis, or GCA. GCA causes irreversible loss of vision and requires prompt high-dose systemic steroids.
And for non-GCA, CRAO.
Initial treatment involves immediate ocular massage and high-flow oxygen, attempting to dislodge the embolus.
Contrast that with central retinal vein occlusion, or CRVO.
CRVO also presents with painless vision loss, but the fundoscopic exam shows diffuse dramatic findings. A swollen optic disc and extensive retinal hemorrhages described as the blood and thunder appearance.
And it's strongly associated with systemic risk factors like hypertension and hypercoagulability.
It is. Treatment focuses on risk factor management and anti-VEGF inhibitors if macular edema results.
Let's quickly cover retinal detachment. What does the patient experience and what do we look for?
Patients typically report a sudden, painless vision loss, often preceded by a sudden shower of floaters from a vitreous hemorrhage and flashing lights, or photopsia.
They often describe a curtain coming across their vision.
Yes. On exam, the key is visualizing the detached retina floating in the posterior chamber. It requires prompt surgical correction to prevent irreversible blindness.
Finally, optic neuritis. We know this has a strong association with multiple sclerosis.
Optic neuritis is inflammation of the optic nerve. Symptoms include painful vision loss, especially pain exacerbated by eye movement, reduced color vision, and the characteristic relative afferent pupillary defect, or RAPD.
And treatment is with high-dose 5E methylprednisolone,
which helps the recovery happen faster, although it doesn't change the final visual acuity outcome.
Moving from pathology to localization, we have to be able to localize the lesion based on pupillary and movement deficits. What is the relative afferent pupillary defect, or Marcus gun pupil, and what does it tell us?
The RAPD signifies damage to the afferent limb, the pathway bringing the light signal in meaning damage to the optic nerve or retina.
And the test is a swing test.
Right. When light is shined into the normal eye, both pupils constrict normally. But when the light is swung to the affected optic nerve, both pupils paradoxically dilate instead of constricting,
signaling the impaired optic nerve cannot sense the light stimulus adequately.
Exactly.
Then we have Horner syndrome, which is a sympathetic issue. Describe the classic triad and where the lesion can occur.
Horner syndrome is sympathetic denervation to the face and eye, presenting with the triad. Plosive drooping of the upper eyelid, miosis, a constricted pupil, and anhidrosis, loss of sweating on the affected side of the face.
And the lesion can be anywhere along that long sympathetic chain.
From the hypothalamus down to the cervical spine. It could be a Pancoast tumor in the lung apex, a carotid artery dissection, or a lateral medullar syndrome.
The most challenging localization is often intranuclear ophthalmoplegia, or INO, which is highly characteristic of MS. What part of the brain is damaged here?
INO is a lesion in the medial longitudinal fasciculus, or MLF. This is the fiber tract that coordinates conjugate horizontal gaze.
And since MS often causes demyelination in the brainstem, it frequently hits the MLF.
It does.
How does this damage manifest when the patient tries to look left or right?
When the patient attempts to look horizontally away from the side of the lesion, the eye on the side of the lesion, the adducting eye, fails to move inward, or adduct.
While at the same time, the abducting eye on the opposite side displays a jerk like nystagmus.
Correct, and the critical distinguishing factor is that the ability to converge, moving the eyes inward to look at a near target, remains intact. If convergence is intact, but adduction during horizontal gaze is impaired, you have an INO.
We wrap up our sensory deep dive with the ear, focusing on the fundamental distinction between hearing loss types and common infections.
And we classify hearing loss based on where sound transmission is impaired, conductive or sensorineural. The Rinn and Weber tests are the high-yield diagnostic tools here.
Starting with sensorineural hearing loss, or SNHL, where is the problem localized?
SNHL means the problem is located in the inner ear, the cochlea, the vestibulocochlear nerve, CNA8, or the internal auditory canal.
Causes include age, noise exposure, ototoxic drugs, or Meniere's disease.
Right. In SNHL, the Rinn test is normal. Air conduction is better than bone conduction, or ACBC. The Weber test localizes the sound to the normal ear.
Now contrast that with conductive hearing loss, or CHL.
CHL is a mechanical obstruction of sound transmission in the external auditory canal, or the middle ear.
Common causes being wax impaction, otitis media, a perforated eardrum, or otosclerosis.
Exactly. In CHL, the Rinn test is abnormal. Bone conduction is better than air conduction, or BCAC. And the Weber test localizes the sound to the affected ear as the sound bypasses the air conduction obstruction.
Acute otitis media, AOM, is the classic middle ear infection.
AOM presents with ear pain, redness, and a bulging immobile tympanic membrane, or TM.
The pathogens are typically the usual suspects: strep pneumo, H. flu, and Moraxella.
First-line treatment is amoxicillin for 10 days. And if fluid remains in the middle ear for 3 months or more without signs of acute inflammation, that's classified as otitis media with effusion, or serous otitis media.
And otitis externa, or swimmer's ear, affects the outer canal.
OE is inflammation of the external auditory canal. It causes pain, itching, and purulent discharge. The key physical finding is tenderness when you move the pinna or the tragus.
The common culprits are Pseudomonas and Staphylococcus.
Right. And treatment relies on topical ear drops, usually a fluoroquinolone steroid combination.
Finally, the potentially lethal evolution of otitis externa.
That is malignant otitis externa, or MOE. This is a severe invasive infection that spreads deep into the bone and surrounding tissues.
And it is seen almost exclusively in diabetic or immunocompromised patients.
Right. And the cause is nearly always a Pseudomonas infection.
And because of that severity in the high-risk population, the treatment has to be highly aggressive.
It requires prompt hospitalization and aggressive IV anti-pseudomonal agents, most commonly IV ciprofloxacin, often for an extended duration. If it's untreated, MOE can spread to cause cranial osteomyelitis and even facial nerve palsy, leading to severe complications.
That was an enormous amount of neurological terrain we just covered. If you look back at our initial sources, we started with a huge list of dense facts about conditions that often share superficial symptoms.
A shuffling gait, confusion, or a loss of vision. And we worked hard to go from that macroscopic presentation right down to the microscopic root cause.
Which allows us to definitively distinguish between these conditions based on their root etiology.
Exactly.
Here's where it gets really interesting. We started with symptoms that look alike, like that shuffling gait, and through pathology, we realized we were talking about completely different systems.
The failure of the dopamine engine in Parkinson's impaired CSF fluid dynamics in NPH, or systemic copper poisoning in Wilson disease.
And in ophthalmology, the difference between gradual open-angle glaucoma and acute closed-angle glaucoma is purely mechanical obstruction, which dictates a completely different emergency response.
And if we connect this to the bigger picture, understanding these specific high-yield differentiations is crucial because early diagnosis determines the prognosis.
Recognizing the one-year rule for PDD versus DLB, identifying the wobbly wet wacky triad for NPH.
Or spotting the cherry red spot in CRAO, these are the high-value pivot points that enable effective intervention, or at least proper planning for fatal conditions like CJD or malignant otitis externa.
We covered how complex, debilitating conditions are often the result of extremely precise molecular errors, such as the single gene mutations that drive those neurocutaneous syndromes.
And that brings us to our final thought for you to consider. We discussed how seemingly unrelated multi-system disorders like neurofibromatosis, type 1 and type 2, tuberous sclerosis, and von Hippel-Lindau syndrome are all rooted in single gene mutations of tumor suppressor pathways.
This raises an important question. If these complex neurological disorders stem from single precise genetic errors, and we now have the molecular tools to identify those errors.
How close are we to finding universally applicable genetic or molecular treatments that can reverse or halt these conditions entirely, rather than just managing the symptoms with dopamine replacement or CSF shunting?
That really is the next frontier of neurology, moving beyond symptomatic management to finding the cure.
It is.
We'll leave you to mull that over. Until the next deep dive, stay curious.